list, and a case for us to think about today was brought by Autumn, Previa Health. Autumn. We'll get our case form pulled up here. We got it up there. Okay.
Looks like I'm
Great.
now. So this is my first time attending. You just want me to go through the entire
Yeah, you could sort of run us through the basics of the case. That'd be great.
Sure. This female is currently 39 years old. Her income source has been a lack of income. She connects with unhealthy men who give her money for her beer, marijuana, drugs. She also gambles the money. She does have money owed to her from back child support. She has 4 children. Hobbies include singing, walking, spending time with family. She has a family history of incarceration. Several of the family members are in and out of jail. Other social factors include physical fights, and I'll give one example in the future. As far as her drug use, she uses alone and with groups. Substance use history includes marijuana, cocaine, opiates, heroin, speed, alcohol, Adderall, nicotine, cigarettes. The use started with this girl as a teenager. Again, family history of use. She started with marijuana, progressing to cocaine, transitioned to narcotics at age 29 when one of her child's father gave her opiates daily. She was in a Suboxone program, or MAT, medication-assisted treatment program, and weaned herself off using Visceral in the dates 2014 to 2015. In April 2016, she restarted in an MAT program. She had relapsed when she used meth due to a breakup. A lot of her issues revolve around men, use. She was incarcerated and resumed MAT following the incarceration. Then she came to a point of daily drinking, Steel Reserve on a daily basis. Consequences of her use, the time frame here. She initially came to our clinic, started with our clinic in 2013, and the initial diagnosis was cellulitis of the upper arm, and following cellulitis in an emergency room visit with abscess. At that point, her youngest son had been removed from her care by CPS. A few years later, she was incarcerated for possession of illegal obtained prescription and disorderly conduct. That same year, 2016, she had unsupervised visits with her 12-year-old son. In October of that year, her son was returned home to her. At age 36, more consequences of her substance use. She had an unplanned pregnancy, voluntary abortion. She spent 30 days in jail for warrant. Continued on 2018. She was in jail out on bond for larceny to a building and resisting and obstructing. Again, 2018, jail for infractions. She served weekends in jail at that point. In 2018, reports of intoxication to unconsciousness. During this altercation, she had a fracture to her finger at a bar, which she couldn't remember. September of 2018, emergency room visit, hematoma as a result of falling off of her bike. In 2018, she had gambled her paycheck and unable to pay for her phone service. Continued to gamble and drink. Coming into this year, a couple more notes. talking to a counselor, that she didn't drink for the past 2 days. She was on Suboxone at the time. She wanted to go back up on her dose of Suboxone to 12 milligrams due to lack of motivation and energy to do anything during that time interview. May of 2019, admitted to having a couple drinks in the aftermath of finding out that a boyfriend was sleeping with her sister and recorded it on her phone. Shows a little bit of the family dysfunction. She thinks that someone put a hallucinogenic in her drink as she became paranoid and was hallucinating. She was seeing all different kinds of snakes. She was arrested at a local gas station. She spent the night in jail. She smoked to calm herself and smoked consistently for 5 days. She went on the following month. She continued to smoke, drink alcohol to take the edge off. She had not been sleeping at her house due to fear of snakes that she thought her ex-boyfriend had put in the house. This ex-boyfriend had tried to give her gifts. He owed her child support money and was trying to get out of paying this. She admitted to sleeping in the bathroom, at a bar, and other places. Her son, the status of her son currently out of the house and is staying with a friend. July of 2019, she's using Adderall, marijuana, drinking alcohol daily. She was evicted from her apartment. In August of this year, she noted being assaulted by a male friend she was staying with and continues to have accommodation problems. She was staying with her mother at that time. Her son continued to stay with a family friend. She made a statement about buying Suboxone off the street to avoid getting sick, additional Suboxone. She was in jail for 4 days. Following jail, homeless, sleeping under the bridge, or in a closet at a boyfriend's house. September of 19, she was sexually assaulted 3 times over the last 2 months while being passed out from drinking and smoking marijuana. The counselor noted her behavior would indicate she may be prostituting herself to support her drinking, marijuana, and gambling habits. Interventions that have been tried with this gal, MAT program and AODA counseling. She was on 8 milligrams of Suboxone films, tapered down to 4 milligrams daily, and weaned herself off using Visceral in that time period of 2014 to 2015. In 2016, she was restarted in the MAT program. She was on Subutex due to the pregnancy and transition to Suboxone. At that point, she had had the voluntary abortion and was transitioned. And most recently, she continued on Suboxone. Most recently, in August of 2019, she stopped coming to the clinic. She had been decreased down to Suboxone 2 milligrams, and that was last filled in August of this year. The AODA counselor that she works with encouraged her many times to begin working with the therapist for her trauma issues, but she's refused. Her mental health related medications include Suboxone only. Her diagnosis, anxiety disorder, mood disorder, and opioid dependence in early remission. Her strengths include caring, outgoing, and friendly. Risk factors, her dependence, homeless. She's currently homeless. She's positive for hepatitis C without follow-up care, including a history of elevated liver function tests. Other risk factors include the sexual assaults, in addition to unprotected sex with unknown infectious disease. So no follow-up with a primary care provider. Labs include the elevated AST/ALT back in 2017, in addition to her hepatitis C. She has refused follow-up testing since, And then most recently, her drug screens have been positive for amphetamines and regularly for the cannabinoids. This patient's goals and motivation for treatment, initially back in 2016, there was a lot of motivation to get her son back. She has since lost contact with her son. He had been living with a friend. He's now in high school and little communication and lives with a friend. She, in September of 19, the counselor would ask, what one area of your life can I help you to stabilize? And she could not tell him. They talked about the importance of finding employment. A treatment plan goal was to reduce her substance use and eventually be substance-free while on Suboxone. Other goals include shelter, food, job, or consistent financial stability, rebuild a relationship with her son, and develop skills to reduce her cravings. Diagnosis, in addition to F11.20, include alcohol dependence and cannabinoids. Proposed treatment plan is seek medical help for hepatitis C and give thought to withdrawal management.
Great, thank you. Complicated case, obviously. Why are we getting the echo there, so to speak? So as usual, I'd like to send this out to the field and our participants outside our shop here and see what clarifying questions or comments you have. See, we got some folks that are just on the phone. Are you able to tell if someone's trying to chip in?
Well, this is Sheila.
Sheila.
Okay, can you hear me? Yeah. As I looked at that very chaotic history, I see there was thought given to withdrawal management. I would recommend that, yes, she goes into an inpatient detox. She needs to be completely detoxed to see what's even going on. Mood disorder is identified, but it strikes me that she has a mood disorder that needs to be treated in conjunction with whatever substance use disorder work that's going to be going on. There's so much happening, and she continues to be victimized, traumatized, and not able to move forward. So if there's any way to fund an inpatient followed by a residential to have that opportunity to actually settle while being actively treated in a co-occurring disorder approach, I think that might be helpful for this individual.
Autumn, are you aware of the sort of resource around you that this young woman might access, or is she already tapped into something along those lines?
It's been presented to her and encouraged for her in the past. There are various reasons why she's declined. One is that she likes to use.
Right.
The other she has various jobs, several jobs that last a short period of time. So if she has a job at the time, she doesn't want to leave. It's like some of the excuses that she presents.
And I'm sorry, I believe you presented this, but I'm not pulling it together in my brain. Has she had frequent hospitalizations recently that are substance related?
Not recently. Those were so back 2013 through 2016.
Okay. And part of the reason I was asking about that is whether, you know, your county might be able to intervene by way of an involuntary commitment to a controlled environment where again, as Sheila was discussing, perhaps there could be some diagnostic clarity as well as therapeutic efforts made, you know, over a course of there. Perhaps followed by recovery housing, you know, if that's available. Is given the complexity of what you're presenting, I might imagine that a fairly prolonged course might be expected for treatment that might be successful for.
Does she have any legals? Is she on paper with probation?
Unfortunately, she does not have a probation officer.
Does she have pending charges?
No.
Interesting with that history. Okay, thank you.
Is she, you mentioned frequent job losses. I saw that she'd received training in nursing. Was she working in that field, or has she worked in other areas?
That was listed a self-report on her social history for her assessment. We have not known her to pursue college classes or anything of that nature.
I guess the other, sorry, go ahead.
Oh, sorry. Yep, this is Ritu Bhatnagar. I was just wondering about the possibility locally. I'm not sure which county you're in around here with if she has Medicaid. One of the resources that can often help stabilize, especially from a housing standpoint, with more wraparound services is the Comprehensive Community Services Program here. And that has made a huge difference for people once they can get in. There's currently a waiting list, but they really provide a very nice wraparound service. So if she's not willing to try residential, sometimes having a case manager, having access to other services. One of the questions I put up in the chat was about potential for PTSD diagnosis and looking at other modalities to try to address her. Seems like there's an underlying cognitive distortion that she doesn't seem that she's worth trying to do things independently without the men that seem to lead her astray and recreate this pattern over and over again. So some of the trauma work can help take her away from that trajectory and offer her a different perspective. And until then, anyway, the case manager can sometimes help quite a bit with providing a solid, positive impact with a person who's actually interested in what's right for her instead of what appears to be right for the man in the picture.
Thank you.
That can also be your route to residential care, should she be open to that. The CCS is the route for the funding under MA.
Oh, yeah, there was a question in our chat here. Kay Olson asking what the legal status of the children is currently. Is there a CHIPS?
I had trouble finding that history. There are 4 children, as stated. There's only reference to one child throughout the histories from 2013 to 2019, and that's the now teenager who would be her 3rd child. I don't know the status, the two older, and then there was a younger child with no reference to what happened to that child, nor does she talk about that child.
Another thought I had was, I'm not sure what you've explored with her about her desire to stop drinking currently. Oftentimes with the Suboxone and the alcohol, depending, we've used it in our clinic as a motivating factor to help her work at either developing ideas to cut down the alcohol use or to sometimes almost use the dosing of Suboxone to help motivate to cut down on the alcohol, if you will. And I've had some success with people actually when they've decided that they want to stop drinking, as a sort of, even in terms of ongoing treatment, if we've continued to go back and forth, and if there's safety concerns from a respiratory suppression standpoint with the alcohol and the Suboxone together. We have used antabuse sometimes, and it has worked. I've talked about this in past sessions, sometimes quite well too if there's concern for cocaine or other substances, and it can help cut down the possibility for that if the alcohol precedes other substance use.
Okay.
If you have access to Vivitrol, that also could be a good option for the comorbid opioid use and the alcohol use disorders.
Yeah, once you get her off of the Suboxone, right? Yeah.
Right, exactly.
Yeah. One additional thought that comes to mind, and I apologize because we don't have the screens up. She's 39, right, with elevated LFTs?
Correct. And the last known lab test was several years ago, so it could possibly be greater at this point.
Okay. The reason I ask is because of the multitude of substances being used, in particular alcohol, and then the repeated physical, whether the fights or other injuries. Has anybody looked at her cognitive function right now? And I'm talking a really simple, like even a slums screening. It is possible she does not at this point have the executive function to put this stuff together. We've had some over the years, particularly with women because it hits earlier than it does with men. We've had some women in their late 30s or early 40s showing some marked cognitive changes related to their substance use, some of which recovered, some of which did not.
Okay, I'll pass that information on. Thank you.
Yeah, in the slums is a really simple screening. The last I knew it wasn't copyrighted, which is one of the reasons we use the St. Louis University mental status.
So, Autumn, is this someone that's still, I wasn't sure I was totally clear on it. Is she still connected with your system and you anticipate following up, or is that unclear?
She has left our clinic as of the end of August. Well, just has not returned. Her script has been completed, so she would be out of Suboxone from us, and she has not come back to the clinic. We have seen her in our community with her suitcase, so it appears that she's carrying her belongings, walking with her suitcase behind her. So that's been our current status with her.
Yeah.
And are you caring for her out of a primary care office then, and then you have a counselor working with you?
No, this is a MAT clinic with AODA counseling.
Okay.
We're attached to a primary care clinic, and we've walked her over to the clinic to attempt to have her follow up with services, and she does not schedule. Other reasons that most recently, she had been bringing in a gentleman with her and didn't want him to know that there were concerns as far as the hepatitis C, so didn't want us to bring her over to the primary care clinic.
I'm just struck by the many layers to this case, and every time I hear more from you, Adam, I'm sort of faced with more ethical quandaries of sort of what is the right thing to do moving forward, just both from a public health standpoint, but also for how to help her and still respect her autonomy and ability to make choices that seemingly don't make sense to providers, but on some level, trying to understand how it makes sense to her may be the way to connect to her, to try to help show her that you're still available and trying to help her the best way that she is able to accept the help.
That was one question I know asked during our meetings, our group meetings, is what role does public health play as far as if with a communicable disease, not notifying partners, but to our knowledge, that's her decision.
Right.
It does seem like she makes a lot of decisions just based out of survival. And the core foundations just aren't being met. She's not eating, she doesn't have a place to live. Seems like she just needs those basics before she can even start looking at not using and getting help for her trauma.
Yeah, I mean, engagement with that community maybe sort of supporting some survival, unfortunately.
She just needs a place to live before she can do much else.
Right. Right.
If she's having cognitive challenges, that becomes very basic this moment survival type things, which is what she's exhibiting.
Exactly.
Right.
And again, as you said, it's hard to tell, is it because of the desperate situation or is it a combination? Because from the description and your timeline, you can see the downward spiral. It appears that things she could do before, she's not doing now.
Correct.
So, Adam, do you have any specific questions beyond what we have talked about? That, I mean, there's, to me, when I'm just, my personal feeling is to try to figure out how to not lose hope for her in hearing the trajectory. And so I'm just wondering if that's something that you and your group have talked about and how you faced and addressed that.
We meet as a group weekly and talk about the client. So we have had quite a few discussions around her care and case. We are kind of at a point where we were looking for more direction, and that's part of bringing the case to this group. And I could bring all this information back to the group also that's been presented.
Yeah, particularly if your organization has further contact, this is definitely one where I think, if there was some follow-up to be had in future months, we'd be interested in hearing about it.
One additional thought, when you mentioned she's out in the community, I apologize, I'm not familiar with your community. Do you have homeless shelters or not?
We do have a homeless shelter, yes.
Okay, does she connect with them at all?
She does not.
Okay.
So her preference has been to stay under the interstate bridge or at a friend's house.
Does anybody go in and do something with a warming shelter or anything like that when we get to November for the folks under the bridge?
Not that I'm aware of.
Okay. You could think about reaching out to Adult Protective Services. No, she's nowhere near 55, but again, she is appearing to be vulnerable. And as it becomes completely unsafe due to just basic weather, if nothing else, the question arises, is she someone who is vulnerable and needs further services, ideally voluntarily, but at least perhaps an offer of something else. But that may be a route into CCS or some other services.
Okay.
Great. Well, thanks again, Autumn. Really appreciate it. And again, if we can make a note and maybe follow up again with Autumn and see about follow up if there's some to be had. So we'll be getting to our didactic here in just 1 minute. Just want to offer, I know we're getting to a lot of you over lunch hour, and you may not want to be seen eating, or maybe you don't have the technology available, but when you're able to, we really appreciate having the video contact by way of a greater fostering of community, and it also helps out a bit by way of flow in terms of seeing who's interested in speaking and asking questions. So whenever it's possible, if you have questions about accessing that, you can reach out to the email included in your materials if there are questions about that technology and access. So Susan.
Yeah, well, thanks for letting me talk a little bit about my role with the liver transplant team. I've been working with the transplant team as a consultant for about 20-some years. And I primarily see the pre-liver transplant patients that are both inpatient and those that come for an outpatient eval. And I have a colleague, Christina Lightborn, that I work with, and she sees some of the outpatient pre-liver transplant, and she follows transplant patients post. So she's an integral part of this as well. So just a quick overview on what we'll be talking about in this brief presentation, just some basic statistics for you, and a little bit of education about what the evaluation process is like from the behavioral health standpoint, and what happens once patients make it, quote, on the list, which is always the goal for them. And then what about relapse? Can we predict who relapses, when, and why they relapse? And just some conclusions about that. Basic stats. The first liver transplant was done in 1963 at the University of Colorado by Dr. Starzl. So it really has not been around as long as you'd think. The UW has been doing transplants, I'm sorry, I don't have the exact date, but since the late 80s, I believe. In 2018, there were 7,526 liver transplants done in the US. And at UW Hospital, there were 112 done. In 2017, 125, and 2016, 105. So it varies some, but not as much as you would expect. These liver transplants include both donor transplants as well as living donor evals, where someone donates a part of their liver, the lobe of their liver. So that includes both numbers. The median wait time at the UW Hospital for a liver is approximately 10.5 months. The wait time varies depending on your blood type and a number of other factors. It's mostly driven once you get on the list by your MELD score, which is just a combination of labs and basically how sick are you and your wait time. There's a lot of great statistics down there on the corner there, those two resources. If you want to get all into stats, have fun and go there. So here at the UW, taking a look at just the diagnosis for alcoholic liver disease and alcoholic hepatitis. Out of the 112 liver transplants done at UW in 2018, 44 of those were done for those two diagnoses, or 39%. In 2017, 46 out of the 125 were done for those two diagnoses, or 37%. And in 2016, it was 45 out of the 105, so 43%. I think the other piece of information that I wish I would have got for you that I didn't, so I will apologize, is it would have been interesting, I think, to look at some of the statistics like back from maybe 2005 to 2010, if we could have looked at those two diagnoses and then added Hep C. Because the numbers would have been closer, anecdotally, I think it would have been closer to like 50% of all the liver transplants could have been correlated back to alcohol or other substances. Now, of course, Hep C is so well treated with medication, people aren't getting transplanted for Hep C anymore. They're getting cured via medication, which is great. But so at one point, UW transplant program, it was closer to about 50%. So the main thing we want to look at too is we know we're transplanting upper 30% of the folks for alcohol-related liver disease. So what are we looking at the relapse rates? So these relapse rates are reported via self-report from the patient to either the physician or the nurse transplant coordinator, or they're found simply through urine or blood tests, ethyl glucopositive path. So in 2018, 8 of those 44 patients that were transplanted for that diagnosis relapsed, or about 18%. 7 of those patients relapsed with alcohol, and 1 relapsed with alcohol and opiates. 4 people agreed to seek outside help, and 1 agreed to be on Suboxone. In 2017, 5 patients out of the 46 relapsed with alcohol, or 11%, and only 1 of those 5 agreed to seek help. In 2016, 15 patients out of the 45 relapsed with alcohol, 1 relapsed with cocaine and heroin, about 33%, and 3 sought help, and 1 started Suboxone. So it's quite a variance. You know, from 2016, we had 33% relapse, and in 2017, only 11%. Again, we don't know exactly why we had such a change in the statistic. anecdotally. Of course, we have all kinds of reasons why. Some of it was the addition of Christina Lightbourne's position. So we had another behavioral health person that was being consistent, talking with patients both in clinic and out of clinic, calling folks, getting people connected to outpatient treatment, being another support system. So her position, I think, certainly helped to decrease the risk of relapse. Still, when you look at those rates, compared to the number of people that relapse after a residential treatment in the first year, it's not so bad. Pretty good. So getting to the actual liver evaluation, who, what, when, why, and how. So how do people actually get to the point of needing a liver evaluation, and how do they get to UW transplant program? They can come in any number of ways. Some patients refer themselves there. Most are referred by their primary care doc or a local GI specialist. Other centers may refer. Some centers may deny a patient and recommend they come to UW. We are the center of excellence for some insurance companies. So patients can come from any way. They may just end up in the ED, and that's the first they're aware of their liver disease, so they come in directly from the emergency department. Why do they come? Patients come at any level of liver disease. They may come in fulminant hepatic failure, or they may come from their primary care doctor saying, I think it's way too early, but let's start the process. That leads into the when. Some people come and they're intubated and they have no idea that they're in fulminant failure and they're critical. Other people come and they're told, nope, you're way too healthy to list. You'll probably never need a liver transplantation. So they leave feeling very happy at the end of their eval. So people come in needing evaluation. It can be done in inpatient, or it can be done during a 2-day outpatient eval. It includes lots of testing, procedures, education, and evaluation. They'll meet with hepatologists, surgeons, nurse transplant coordinators, social workers, dietitians, financial, and when indicated, they'll meet with behavioral health therapists such as myself. The actual assessment that we do for folks is impacted by a number of factors. It's impacted whether they're an inpatient at the time of the evaluation or they're an outpatient. Both of those have the pros and cons. Inpatient folks tend to be sicker, but they also tend to be kind of a captive audience. They're often ready to talk. They're expecting to talk to people. As an outpatient, they're meeting 6 or 7 people all day long, so they're giving their history over and over and over. When they come as an outpatient, they're expected to bring support people with them. When they're in the hospital, they may or may not have a support person with them. Sometimes when they're in inpatient and they're in the ICU, I may not be able to interview them at all, so I have to gather information from a chart review or from talking with family. And again, family may or may not know the extent of the patient's substance use. There's always a level of urgency if they're in the ICU. Sometimes they may not be expected to live more than a couple of days without transplantation. So there's a sense of urgency to get as much as you can information regarding a patient's history from chart review and family. What the assessment actually contains is certainly demographics. You want the basics, kind of where do they live, what's the story behind who they are. You want to get as much substance use history based on the DSM as you can, including all substance use, not just alcohol or IV use. Do they have any mental health history? Do they have a history of abuse or trauma? Do they have a history of AODA or mental health treatment? Are there currently safety concerns? is there family history of substance use or mental health disorders, and what have the medical consequences and the patient's level of awareness. The medical consequences, it seems like a given. They should know, yeah, they're here for a liver eval, that they know that their liver has been impacted by their alcohol use. I always start out the eval asking them, what's your liver disease from? I think it's important to find out what their awareness is, and many times I will get the answer, they don't really know yet, where you read in the chart it's been explained over and over that it's from alcohol. Or I may get the answer, I drank too much. It really can give you the starting point for my understanding of what the patient's level of awareness is. So this assessment really is not anything unique to any other behavioral health assessment that you're doing. So what are the recommendations that are most commonly made after an assessment? Clearly abstinence. And we make the recommendation of abstinence from all substances, not just the alcohol. We are often challenged with the abstinence requirement of marijuana. We certainly recommend abstinence from marijuana if they have a history of any addiction. What do we do? What kind of referral do we make? It somewhat depends on how long the patient's been abstinent. Kind of the rule of thumb with the transplant coordinators is if anyone has used alcohol or has a history of an alcohol use disorder within the last 3 years, they want them to be seen by a behavioral health therapist such as myself or Christina. So if someone's been sober for 2.5 years, I'm probably not going to send them back to any kind of outpatient treatment if I feel like they really have an understanding of their alcohol use disorder and they've been able to maintain abstinence. We may look at what are they doing, what's their current support network. Some people go to AA, some people like Smart Recovery, some people don't like peer support at all. Some people need referral to mental health counseling. They have anxiety or depression, bipolar. We also encourage any kind of alternative support systems, such as mindfulness, yoga. There are lots of good apps out there. We look at friends. And often we will make the recommendation to the team that they do random urine and blood screening, looking for utilizing the ethyl groups in the path. So if someone makes it to the list, and making it to the list means that they have, their case has been presented. We present patients once a week in the liver selection committee meeting, which I attend weekly. Everyone that has had any input in that patient's evaluation provides feedback to the team regarding their piece of the patient's workup. So if everything fits and they make it to the list, what do we do then? This is where there's ongoing monitoring of the patient's abstinence. If they were referred to some counseling, there's communication with the patient as well as the local provider, because most of our patients are not from the Madison area. We always have continued contact with the patient's support people, and again, the random screens. The ethyl group detects alcohol for up to 80 hours, but the PEth detects heavy drinking within the previous 3 to 4 weeks. Takes about 4 days to get back though, so that test does take a while, and it's expensive. So what about relapsing after liver transplant? Are there predictable factors? Yes and no. There's been a lot of literature written about this. Some written by Dr. Michael Lucy, who is a hepatologist with the UW. You can be lost in the research for days regarding this. Christina and I have done a lot of looking to try to come up with some kind of tool that she and I can use to look at, can we come up with our own relapse predicting screener. This article that's cited here took a look at 51 articles and tried to lump the variables. They came up with these 5 broad categories. The first is the ever popular 6-month rule. So when I started working with the transplant program, it was a hard rule that patients had to be abstinent for 6 months. That is still the rule for many, many transplant centers across the country. Some transplant centers will not even evaluate patients until they have been abstinent for 6 months. That is not the case at UW for any number of reasons. Each case is looked at individually. So Dr. Lucy will say that the 6-month rule is arbitrary. However, the research does show that the longer the period of abstinence, the lower the relapse risk. The second variable, or the risk factor category, is just looking at duration of use. Number of drinks per day, the higher the number, the family history of alcohol use disorder, and the earlier someone went to treatment, the higher the risk of relapse. Social factors, of course, common sense. If they have a lack of stable relationships, lack of support, if they're continuing to engage in social activities that are alcohol related, they're still going down to the same bar, but now they're drinking soda. All those things that indicate that awareness really hasn't sunk in or behaviors haven't changed. The comorbidity of any kind of mental health disorder is also a risk factor. So again, we screen for those mental health things and assist people in getting some counseling for that. And then just the final category is really looking at just compliance in general and motivational characteristics. Have they accepted the alcohol use diagnosis? How has their compliance been in general with follow-up, not just with AODA counseling, but in general with medical care? So in conclusion, liver transplant saves lives. Treatment for AODA issues saves life. Liver transplantation is not treatment for an alcohol use disorder. We emphasize over and over and over to patients as well as to the staff. These are two different diseases that need two different treatments. Liver transplantation does not ensure that someone will not drink again. They need to have the disease of their alcohol use disorder treated in order to maintain abstinence, just the same as they need to have their liver transplantation in order to effectively transplant and maintain their healthy life.
Thanks a lot.
Yeah,
Susan.
questions?
Yeah, any questions or discussion?
This is Sheila. Just one thing, this last slide. Absolutely. Because I can recall over the years, people having this concept, well, after going through a liver transplant, they certainly understand why they can't drink now. And it's like, they didn't have a brain transplant. They had a liver transplant.
Yeah.
So indeed, very, very important.
Yeah. I think sometimes that's a hard thing for
Yes.
some transplant staff to understand, because
And
it is
families. And families.
Yeah, and seeing the transplantation as the gift of life, which it certainly is, but that's not treating the addiction. And I believe people that are pre-liver transplant, and I believe them wholeheartedly when they say, I will never drink again. I would never do that to the donor family. And I believe them at that time. That is what they believe. But it's an addiction, so we still have to treat the alcohol use disorder.
Right. Because that neurobiology is there, and then some of the medications post-transplant seem to sometimes make things more difficult unless they've got a solid recovery.
Exactly.
So yeah, so I appreciate that last slide a lot. Thanks.
Mm-hmm.
Yeah, I also noticed, and I've noticed sort of in practice at UW Hospital, in years past, it seemed like really the indication around transplant was pretty heavily, if not near exclusively, for cirrhosis, but where we're starting to see more consideration for alcoholic hepatitis. Is that true, or are you seeing that increase more, or is that?
I think we are seeing that more, and I think on the inpatient unit, we're seeing people come in with acute ALCHEP, and then they'll do a quick trial of the steroids while they're inpatient, and if they don't respond to the steroids, they're quickly then get targeted toward transplant.
Okay,
so they're non-responders to the steroid.
And on the distant end, the steroids seems to have made a huge difference in what we see on cases.
Mm-hmm.
People seem to progress fairly quickly to needing transplant. And now we've seen a number of people, as you say, turn around and not head down that direction. So that's been very interesting over the decades watching that change.
Mm-hmm. Other issue I imagine crops up, I mean, this being a referral center, is that a lot of people may come from areas where they may not have all the resources that they need. And I wonder sort of how that discussion goes. Say if someone's from a rural area where they may not have access to the resources the team thinks of as optimal. Like, what does that conversation look like when you have someone in that kind of situation?
Yeah, I think that does come up a lot, and it ends up to not just being the AODA resources, but it's not unusual where I'm asking someone to travel, 30, 40 miles to go to an outpatient counseling, and then social work is also asking them to, develop a good support system when they really have no family in the area. They've kind of alienated themselves from friends, so they've got no one that can come in and stay with them. They've got an uncle that lives in California. It's really hard sometimes for people to pull together what is a necessary support team post-transplant.
Right.
So it takes a lot of work on a lot of levels. So even though medically they may be ready for transplant, the psychosocial stuff is really important and takes a lot of time to work on.
Yeah, I mean, and there's a lot of work to do is sort of leading up to around the time of and after a transplant. Are there resources, individuals as part of the transplant program that can do some of that outreach, if not just by phone? And
I think there are. The pre-transplant social workers do a lot of that work, helping with patients, and there are systems in place. With home health, they use the same types of resources that any outpatient would use, but patients do fundraising. The medications are so expensive, and if you have a 20% copay with transplant, you're going to be bankrupt. So there's a lot of offshoots. Pharmaceutical companies donating some meds, and the social workers are amazingly great at problem solving. I give a lot of kudos to them.
Oh, the other thing that I was kind of wondering about, you mentioned sort of the assessment around, eligibility involved. So are there pretty strict guidelines around what that needs to look like? And are those at an institutional level or some level beyond that? Or?
So the AODA assessment really just needs to follow JACO regulations. There's not additional requirements from the transplant. We just need it to be consistent with every patient. The social workers have started to use a CSAC score, which is, I can't remember what it stands for, but it is a scoring tool that is used nationally. So they get an actual number from 0 to, I believe it's 120, which helps people fall into a category of risk, which counts all kinds of psychosocial issues. So you may fall into a category that says that you're a poor compliance. So there will be strict things they have to do to increase their score or lower their score. So.
Great. Well, thanks again.
Sure.
Really appreciate it. I see we're at the end of our hour. Thanks for coming. Again, we'll be getting together again at the same time today, October 18th, when Lindsay will be presenting around women, trauma, and substance use disorders. And again, if you're able, join by video. If you're eating lunch, we don't mind. Maybe we'll do the same, make it more customary.
There you go.
Thanks a lot for coming.
Bye.
Thank you.
Dr. Brown, quick question. This is Sheila. Can we perhaps, or we've been cut off? Can you hear me?
Yeah.
Okay. We're seeing injection of Suboxone. I'm wondering if we can talk about that next time a little bit.
Great. We will
I'm not saying like
what's
one person.
happening with cases and things. Since we already have a didactic, we'll need to see what happens with cases. But if not next month, we could slate it for November, certainly.
That would be fine. It's just really popped up and we're surprised with the frequency that we're seeing it.
Yeah.
Thank you.
Oh, okay. All right. Thanks, Sheila.
Yep, bye.